everyone. We will start recording this. If I could ask
Recording
you
in
all to mute
progress.
yourself, please, because there's some like rumbling background noises. Okay. Hi, everyone. So welcome to this session's Zoom lectures of the Sydney Neonatal Lectures. And the speaker here doesn't really need an introduction, but I will just do a brief intro for him anyway. Thank you, Lex Doyle, for agreeing to talk to us today. Lex, as you know, was the PI of the DART study that introduced us to the use of low-dose dexamethasone for extubation. But I guess over the last 30 years almost, isn't it, Lex, that, the use of dexamethasone has really undergone massive therapeutic drift. And now Lex is here to tell us what is happening with the use of postnatal steroids for children with bronchopulmonary dysplasia or BPD. So the floor is yours, Lex. We'll take questions at the end. So if you have any questions, type it on the chat pane, or after Lex finishes, just raise your hand with the reaction button, and he'll answer them. All right, over to you, Lex. Thank you so much.
Thanks, Julie. I think everyone needs to mute their computers because I can hear a lot of chatter in the background. Okay.
Sorry, Lex, I've muted you.
Yeah, I saw that.
I know. There was
on my back.
I'm muting everyone, so don't be offended.
I tell you what, I'll just put it in.
Okay.
Okay, I need to declare that I'm the author on several Cochrane systematic reviews on this particular topic, and you'll hear from most of those today. As Julie mentioned, I am the Chief Investigator A on the DART study, which was many years ago. We completed that about 20 years ago now. And I am a Chief Investigator on the current PLUS study, which I'll allude to shortly. There's a subtle distinction between those two words. So the issue with postnatal corticosteroids when you're considering treating a baby for BPD is, do they do more good than harm, or do they do more harm than good? It's a balance of risk versus benefits. And the risks and benefits could be short-term, including things such as death or BPD. They could be long-term, again, including death, because it's ultimately a longer-term survival that's more important than the short-term. But includes things like intellectual or sensory impairment or cerebral palsy or respiratory outcomes or anything else that you might be particularly interested in. And the thing about this is you have the competing risks such that mortality versus BPD or cerebral palsy are all possible outcomes when you're considering treatment. And you can't have BPD or cerebral palsy if you don't live long enough, if you don't get to that endpoint. We have to consider the balance between these things.
We can listen to this is very important.
Somebody's talking in the background.
Yeah, if everyone could just mute themselves when they come on, that'd be great. Thank you.
So, sorry. The major outcomes I'll talk about are mortality, BPD, and the combination of mortality or BPD. And in terms of longer-term outcomes, cerebral palsy or mortality or cerebral palsy. And the reason I'm focusing on these outcomes is because these are the outcomes with the most data, rather than necessarily being the most important. So, first of all, what drugs are being used currently, as best we know, for these babies who are potentially developing BPD? And what is the evidence for these different drugs? There was a publication just last year from 7 high-income countries talking about or reporting the amount of postnatal corticosteroids that have been used in a total of 47,000 infants in 24 to 28 weeks. And the use had increased over time from 18% in 2010 to 26% in 2018. And as you would expect, those who are most immature, 24 weeks, 49% of those babies were treated with postnatal corticosteroids, whereas only 7% at 28 weeks were. So corticosteroids are certainly being used around the world, and their use perhaps is on the increase again. which particular postnatal corticosteroids are being used. This is data from the Neonatal Research Network in England and Wales. All babies less than 32 weeks, 60-odd thousand, 13% or 8,000 had been treated with a postnatal corticosteroid. The predominant one was dexamethasone, but others being used include prednisolone and methylprednisolone, inhaled budesonide, and hydrocortisone, both early or late. Early being in the first days after birth, and late usually after the first week. So there's a range of different drugs being used through different modes. Similarly, from 11 European countries, more than 10 years ago now, dexamethasone was the predominant corticosteroid, but hydrocortisone was being used almost equally, and there were a substantial number of babies being treated with betamethasone. You can see there's lots of variation. What's the evidence for these different drugs that are being used? Well, there's no evidence at all from randomized controlled trials for prednisolone or methylprednisolone or for betamethasone. So anyone who's using those drugs are using them completely without any evidence at all. And presumably they're using them because of personal choice or for other reasons or theoretical reasons or data from animal studies or something that's not related to human trial data. So of the other medications, they are used either systemically or potentially directly into the lung, either through inhalation or through intratracheal injection. And there are different types of drugs being used both those ways. So this is where the evidence does exist, and we need to review what the evidence is for these particular types and methods of administration. So in terms of systemic versus inhaled or intratracheal, you could look at data where there's been a direct comparison between the two types. You can look at just inhaled or intratracheal only. You can look at systemic only. We can then consider the clinical implications of all of this and then also the research implications. Firstly, with respect to direct comparisons, if you want to look for evidence, the place you should always start is the Cochrane Library, because chances are someone's done a review of the particular topic and they've reported the results. So if we look in the Cochrane Library, we'll find that there are a couple of reviews dealing with systemic versus inhaled, both prevention and treatment. So the first one on prevention and the second one on treatment are by the same group of authors, published around the same time. So they are a little bit out of date, but they are the most current evidence we've got. Firstly, inhaled versus systemic corticosteroids to prevent BPD. There are limited data. There have been only 2 studies with a total of 294 participants, and there have been rather complex designs with different types of dosages being manipulated as well as different drugs. But in terms of the evidence of those 5 main outcomes, firstly, with respect to BPD at 36 weeks, the rate in the inhaled group, 34%, the rate in the systemic group, 24%, with a risk ratio that's suggesting there's some benefit, but it's only coming from 1 study with a total of 278 participants. We add the mortality data, much the same rate, and the combination mortality of BPD, it's a little bit higher in the inhaled group. I should have said at the start, the reason these outcomes are described this way as bad outcomes is that's because that's the way Cochrane makes you report things. They always want you to talk about bad outcomes and reducing the risk of bad outcomes. That's what you're aiming to do. Whereas in English, you'd probably want to say, well, I'm interested in the rate of survival for BPD. So that's how you would think clinically. You're giving something to prevent the baby getting BPD, but also being alive. But anyway, we'll have to talk in a negative sense, if you like. In terms of cerebral palsy, not much difference in the rates, but only 1 study, 91 participants, not much data to hang your hat on. And the combined outcome of mortality of cerebral palsy, not much difference, again, based on the 1 study. So I've gone through that rather slowly, and the next times I show you these data, I'll be much quicker. I'm just going through it one by one so you understand the distinction between the different outcomes. What about inhaled versus systemic to treat BPD? Again, there are limited data. There are 3 studies with 431 participants, but again, there's complex designs in these studies, which I won't go into here. But here are the 5 outcomes. And overall, what you can see is not a lot going on comparing inhaled versus systemic. So the trouble with these direct comparisons is there's really little evidence of benefit or harm with complex study designs and few studies or participants. So you really can't draw much conclusion in terms of comparing one mode over the other. What about inhaled or intratracheal only? In terms of inhaled corticosteroids, there are 2 Cochrane reviews, one by Sharadel in 2017 for early studies, and the second by Onland and Al for later studies, early and later referring to the time of starting treatment, early in the first days after birth versus later, usually after the first week or 2. Here are the 5 outcomes here. Here we've got more studies and more participants. You can see over here on the right-hand side, if I can get my little arrow up, 6 studies to over 1,000 participants. There you've got more certainty here. And here there is something going on. There's a reduction in the rate of BPD at 36 weeks. There's a reduction in the rate of mortality of BPD. However, if you look at mortality or CP, there's an increase. So this is a little bit worrying. You're having some early benefit, but evidence of later harm. So if we look at these data in a bit more detail, the CP rate of follow-up is much the same in these 3 studies, but the death before follow-up was fully increased, which is why the combination of CP was increased. That's where the problem lies. And it's partly coming from this one study. And this particular study by Bassler et al., published in the New England Journal now 9 years ago, contributes 2/3 of participants to the review, so it has a big influence on the results. In this particular trial, they used budesonide virus spacer, and here are the doses. And what they found in their particular study was you reduced death or BPD. Good news. That's probably why it got into the New England Journal. However, what it was doing was reducing BPD, but there was an increase in the death rate. Now, not above the magic statistical significance, but still enough to be worrying. A 5% absolute increase in death is a concern. Interestingly, in this study, 2/3 of the participants were intubated and ventilated, and there was little effect of early inhaled corticosteroids. It was in the 1/3 who weren't intubated where they had the most reduction in death or BPD, which to me seems a little bit strange, but that's what they found. When they followed them up, and again, this was reported in the New England Journal, the death rate had actually gone up and now was above the magic 0.05%, 0.05 for p-value. So that was confirming that there was an increase in mortality in this particular study, and the cerebral palsy rates were much the same. I mean, the death or CP was marginally up. So in terms of early inhaled corticosteroids to prevent or treat BPD in clinical practice, to me, the increase in mortality outweighs the reduction in BPD at 36 weeks, and therefore you cannot recommend early inhaled corticosteroids to prevent BPD. What about later inhaled corticosteroids? In Wes Onland's review, he had 8 trials, 218 participants, but only 1 trial reported BPD and only 3 trials reported mortality, and no trials reported any long-term outcome. And so you've got over here 1 study, 30 participants, 3 studies, 61 participants. You really can't draw any conclusions whatsoever from the data, but they're the data that exists. So basically, the drugs haven't been studied efficiently in older children. There's insufficient data to guide the clinical practice here. What about intratracheal injection of corticosteroids? This is a topic that's increasing in interest. And in fact, there's just been a new systematic review, which I came across just last week. I hadn't realised it had come out, but this has been published in a journal I've never heard of, but Respiratory Medicine Research. I suspect it's a full fee-paying journal somewhere, but I've never heard of it before. But anyway, it's got 85 volumes. Someone must know something about it. Now, this is an interesting review because it includes a whole lot of drugs and a whole lot of methods different methods of giving it, either inhalation or direct injection. And very complicated. This is only part of the number of studies in the review, but I just wanted to highlight 13 trials that actually involve budesonide in surfactant, which is what I'm going to focus on rather than just the inhaled data. So 13 trials in this particular systematic review. In terms of what's in the review, they're supposed to be randomized controlled trials, but it worries me that when you see in one particular study there's 138 infants being randomly allocated to treatment, but only 46 controls. Now, I don't know of any coin that is a fair coin with heads and tails on that would get anywhere near that number of 138 heads versus 46 tails if you toss it up a couple of hundred times. So there's something wrong with the data here. Now, the problem is most of these studies come from the Republic of China and they're published in Chinese. And I'm sorry, I don't read Chinese, so I can't go to the individual reports and try to figure out what's going on. But this particular study worries me when I see that. That's a concern. There was an earlier systematic review published in something called Current Medical Science. Again, I'm not too sure what journal that is, but there were two studies in the 2019 review that weren't included in the 2024 review. They both happen to be also from the Republic of China. If I put all those 15 studies together and come up with the same sort of table that I've been showing, or same sort of data that I've been showing you before, you'll see there's a substantial reduction in BPD in the intratracheal group in surfactant compared with control. There's a reduction in mortality, and there's clearly a reduction in mortality or BPD, but there are no long-term outcome data. There are risk ratios and tight confidence intervals, and you'd be thinking, well, why the hell aren't we using intratracheal corticosteroids in surfactant currently on this evidence? Very strong. Now, there's a little bit of a warning here. Now, Brett Manley's been going around the world talking about the results of the PLUS study. The manuscript's currently under review, so please don't reproduce the data anywhere. But if he's allowed to talk about it, so am I. So I'll tell you a little bit about the results of the short-term results of PLUS. In PLUS, we recruited babies less than 28 weeks within the first 48 hours after birth who needed surfactant. That's basically the inclusion criteria. And they were randomly allocated to either budesonide in surfactant, and if it was the first dose of surfactant, it was 200 milligram per kilo. If it was the second dose of surfactant, it was 100 milligram per kilo, and the surfactant used was Curacert. You could get a second dose within 6 to 12 hours after the first one if the clinicians thought that the baby needed more surfactant. And in PLUS, 80% of babies were intubated at enrolment. In terms of the big outcomes that we've been talking about, within PLUS, BPD rates were identical between budesonide and control, not reduced, identical. Mortality rate, a few percent lower. Combination rate, mortality or BPD, a few percent lower. So no dramatic effect within the local randomized controlled trial, the biggest and the best designed and the most robust. The children are being followed up at 24 months, but they haven't turned that age yet. Some have, but the majority haven't yet. So we have to wait for the longer term outcome result. If we go back to this slide I showed you earlier, and you look at the inclusion criteria, you'll see the babies are relatively mature or heavy when they're included, but as I said, I can't go to the individual studies to work out the mean birth weight and mean gestational age. But for the two studies from Taiwan down here, you can see the mean gestational ages are around 26.4 weeks or thereabouts. And in PLUS, they were a week earlier. So PLUS is dealing with the sickest and the most immature and tiniest babies. And that's perhaps why it's not showing the positive results that these other studies are showing, where the babies perhaps weren't as such high risk. We add plus to the data that I've already shown you. We now end up with 16 trials, 2,800 plus participants. You might think we'll get a clear-cut answer. You still find an overall benefit. But what adding plus does is it adds substantial heterogeneity to all these results, which did not previously exist, which tells you be careful pooling these data. There's something systematically different between plus, the local trial, and the other trials which are predominantly coming from elsewhere. So there's a warning here. We shouldn't be rushing into the plus style treatment, budesonide and surfactant, just yet. We need to understand what's going on in those randomized controlled trials from China. If anyone's going to do this, they need to be able to speak Chinese. We clearly need further randomized controlled trials, but the most important data to me are not the short-term outcomes, but the longer-term outcomes. And PLUS is one of the randomized controlled trials that is following the children. And to my view, in my viewpoint, it's the longer-term outcome data that will trump anything to do with the short-term outcomes. There, fortunately, is a big network trial in the US where they are doing a very similar study to PLUS, but they're still probably a year or two behind where we are. Brett may know more about that if he's online. Okay, what about systemic medication only? There are 2 reviews in the Cochrane Library, both now 2.5 years old. They are grouped by when the drugs were started, either in the first week of life, they're called early trials, or after the first week of life, they're called the late trials. And in terms of the total numbers of studies and participants and the drugs, they divided into dexamethasone and hydrocortisone, early and late. And here are the absolute numbers that you can see. So 55 randomized controlled trials, over 6,000 participants. You might think after all that, we'd have a very clear idea of what we're doing with these particular drugs. Well, I'm afraid the message isn't as clear as you might like. This is just one of the forest plots. I won't show you a whole bunch of forest plots, but this is early systemic corticosteroids. The outcome is mortality at the latest age. In other words, the oldest the children might be. In some cases, that might only be the hospital discharge. In a lot, it might be the follow-up at 2 or 3 years of age, and in some others, it might even be into later childhood. But overall, I don't expect you to read the fine print here, but overall for dexamethasone, there's no effect on mortality at the later stage, risk ratio 1.02. For hydrocortisone, there is a reduction, 0.8, with upper confidence interval of 0.99. And overall, combining both dexamethasone and hydrocortisone, there's not much evidence of benefit, but there is evidence of a differential effect between hydrocortisone and dexamethasone, which we need to understand. In terms of other benefits, I thought you might be interested in other things that might be beneficial, including your kidneys extubated. This is reduction in failure to extubate. This is the negative language I hate, but to me, the baby get extubated, you avoid late steroids, you have less trouble with the blood, you avoid problems with severe retinopathy over and above the effects on BPD or death. But these come at a cost. You have high blood glucose and high blood pressure, you break the gut more often, you have more gut bleeding, you have an increase in rate of cerebral palsy and an increase in rate of fetal cerebral palsy. So early dexamethasone is harmful in the longer term. So if we look at the 5 big outcomes, reduction in BPD, reduction in mortality or BPD, but an increase in cerebral palsy and mortality or cerebral palsy. And so in clinical practice, the benefits of early dexamethasone do not outweigh the risks, and therefore early dexamethasone is not recommended for routine practice. What about hydrocortisone? We said there was something going on here. here are some of the other benefits. You get babies extubated, you avoid late steroids, you don't avoid late steroids, you have less problems with the duct. So there are some other benefits with early hydrocortisone, but it's the effect on BPD and mortality which is intriguing. In terms of harm, you more gut perforation, but you don't have the other harms that we saw with dexamethasone. Why might early hydrocortisone be beneficial? And again, it comes back to one influential study from the French group on Olivier Bauer, published in Lancet, where they recruited babies from 24 to 27 weeks, less than 24 hours of age. And they randomly allocated them to quite a low dose of hydrocortisone over the first 10 days versus placebo. And they had a planned sample size of 786, but they stopped only 2/3 of the way through after 6 years. They say because they ran out of money. However, they were looking at the data after every 100 participants, and they did stop at a point where they achieved a reduction in death or BPD, which was just on the cusp of statistical significance. Now, this particular p-value, 0.04, is what they published in the paper, and they said it was adjusted for the multiple looks as well as gestational age. This risk ratio, they didn't report a risk ratio, they reported the odds ratio and the risk difference. This is just a risk ratio you get if you put the data into RevMan or any other program, and it comes up with the same p-value. Now, you can't adjust the p-value that's in Cochrane for the fact that they had multiple looks, unfortunately. So it gets in as it is, and it seems impressive. I just can't see the bottom of my own here because I've got others in the way and I can't remember what's there. But anyway, if I can get this thing out of the way, I'll just do it there because operation was not increased. I knew there was something else I needed to comment on. Now that I fiddle with it, it won't advance anymore. There you go. The technology always escapes me. Come on, there we go. So we go into this particular trial a little bit more detail. They randomly allocated 256 or 267 in both groups. One family withdrew consent. When they followed them up, some had died, but the mortality rate was lower in the hydrocortisone group. And of the children who got to 22 months corrected age, they saw most of them, over 90%, which is excellent. But over 3/4 of them had a formal developmental test. And they were looking for things like moderate severe neurodevelopmental impairment and abnormal neurological exam. So of the children assessed, there was no real difference in cerebral palsy. There was a bit of a reduction in those with a low developmental quotient on their particular test that they used. And in terms of abnormal examination, neurologically, much the same rate. And overall neurodevelopmental impairment was much the same between the two groups. At the same time they were reporting, there was one of the early hydrocortisone studies that was reporting data at 5 to 7 years of age, which is far more important data if you've got it. Trouble is, this is a particularly small study. You can see the sample sizes here. But when they did their neuropsychological assessment, they found overall that the verbal IQ was much the same, but the performance IQ was much lower in the hydrocortisone group. The overall combined IQ was lower in the hydrocortisone group, but the reduction was less impressive. In terms of abnormal neurological exam or cerebral palsy, it seemed like more of the hydrocortisone kids had trouble, but because of the small sample size, we can't comment about this. The evidence for this is a weak finding. Now, the French group subsequently went on and assessed some of their children at school age, but only from one particular centre. So of all the survivors to 2 years, they only assessed a total of 40 from one centre in each of the two groups. So this was 76% of survivors from this one large centre. And in contrast with the Finnish study from Postnatal, which I show on the left, what they found in terms of verbal IQ, performance IQ, and overall IQ were different results to the Finnish study. Obviously, the French study was consistent with no harm. whereas the Finnish study was concerning. The French actually showed a positive increase, or evidence for a positive increase in the working memory index, which is one of the subscales of IQ. However, there were a number with missing data, and those with missing data may have had worse outcomes than those with data, so we just don't know about that. If we look at overall the 5 major outcomes with early hydrocortisone, there is a reduction in mortality or BPD, but you just have to wonder how much influence that French study has, because if you take out that study, those differences diminish and the evidence becomes weak that there's any effect on mortality or BPD. So early hydrocortisone may be having some effects in the doses used, but it can't be recommended routinely to prevent BPD just yet. It really needs further research, particularly with these conflicting longer-term follow-up data. And so further trials need to be designed and carried out with neurodevelopment as the primary outcome, not BPD. What about late systemic corticosteroids? Here's the forest plot for these particular drugs. And just to summarise for you, with dexamethasone, there's a bit of a reduction, but the evidence is weak. That's statistically important. There's a bit of a reduction with hydrocortisone, which looks a bit more impressive. But if you combine them overall, there is a reduction in mortality if you use late systemic corticosteroids. And there's no evidence for a subgroup difference here. Since the Cochrane review, the large network trial by Christy Waterberg was published in the New England Journal, where they recruited babies under 30 weeks gestation who were intubated for at least 7 days and were still intubated between 14 to 28 days after birth. And they were randomly allocated to 18 milligrams of hydrocortisone over 18 days or placebo. And they had a total of 800 children overall in this particular study, with mortality rates that were much the same. If we add the Waterberg study to the Cochrane review, you find that the the risk ratio for mortality comes closer to the dexamethasone group, and combined, you still have a benefit. But individually between dexamethasone, there's no real difference, and there's no evidence for a subgroup difference between the 2 drugs. Look at all the other potential benefits from late dexamethasone. Again, you get babies extubated, you avoid having to give them open label steroids, and you get fewer home on oxygen. All good outcomes. Are there bad things? Yes. High blood glucose, glucose in the urine, high blood pressure, cardiomyopathy, all those things go away when you stop the drug. Potentially an increase in severe RAP, which in fact doesn't translate into an increase in blindness. And in one particular study, there was a higher rate of abnormal neurological exam when that outcome was reported. So there are potentially some harms. But if you look at the 5 big diagnoses, with late dexamethasone, you get a substantial reduction in BPD, and you get a substantial reduction in mortality or BPD without any evidence really of long-term harm, certainly no increase in mortality or CP combined. The benefits still may not outweigh the potential harms, and we'll get on to where it might vary in a minute. But it means that you really should be reserving dexamethasone for the sickest babies and those who are ventilator dependent. This is what we concluded in the Cochrane review, and you probably should be minimising the dose. These are the conclusions of the Cochrane review back in 2021, and they aren't really changed today. What about late hydrocortisone? 3 trials, 1,200 plus participants. In terms of mortality at 36 weeks, we talked about the reduction there. But what's more important is longer-term mortality. And when you look at the data for an improvement in longer mortality, it's much weaker. The hydrocortisone has other effects. It again puts up your blood glucose and your blood pressure, but otherwise doesn't seem to be too harmful in the doses that are used. However, there really are insufficient data to justify clinical use of late hydrocortisone. What other approaches have been taken to try and sort all this mess out? there's something called network meta-analysis, which I have to confess I was part of. And what network meta-analysis does is allows comparisons of treatment options that have not been compared with each other directly previously. Within this network meta-analysis, which is now published in the Cochrane Library, we focused on different doses of dexamethasone and hydrocortisone and compared with placebo or other systemic corticosteroids, and we looked at this in 2 times, both early and late. In terms of the total numbers of trials, lots of participants, but only in 6 studies are there direct comparisons, and therefore you need to rely heavily on indirect evidence through comparisons with either placebo or no treatment group. And what I mean by an indirect comparison, if A is worse than B and B is worse than C, but you have no direct comparison between A and C, you can still probably conclude that A is worse than C. That's basically how it works. That's my understanding of it. If I've got it wrong, please correct me. In terms of the trial, 31 were early, 27 were late, and 1 there was information both early and late. And what you come up with is a big circle telling you how many sort of people are in control groups, and you've got different categories of high dose dexamethasone, low dose dexamethasone. Can't see what that says again. I have to move it. Hydrocortisone and moderate dose dexamethasone. And then you come up with this sort of forest plot, which is all over the place in terms of what it's trying to tell you, but it basically divides the comparisons. High dose dexamethasone versus hydrocortisone, you've got direct estimates, no data. Indirect estimate, the sort of risk ratio and its confidence intervals and the overall network estimate, and so forth down the page. So it's comparing all those different combinations that I was talking about. Sorry, since I've been fiddling, it won't move forward. In terms of the late group, again, you've got a big number in the control group and the 4 different categories, but here you do have different comparisons between different dosages. And the thickness of the line is proportional to the number of studies that might contribute to that. And here's the forest plot again, but I'll just point out the direct comparisons, you really don't have a whole lot of data relating to direct comparisons between different dosages to tell you what's going on. So it's really quite confusing, this network meta-analysis, even for me as an author. So in conclusions from this, it looked like moderate dose dex was best for death or BPD with moderate certainty evidence. Low dose dex was worse for the cerebral palsy, gut perforation and hypertension. Late systemic high dose dex was best for death or BPD compared with placebo, with high certainty evidence, confidence data, and all other treatments, low certainty evidence. Moderate dose dex was worse for sepsis and hypertension, but no clear winner for cerebral palsy with low power. Unfortunately, the clinical conclusion from all of this is that there's insufficient evidence to guide which drug you should use, what dose, when should you use it, with regard to plausible adverse long-term outcomes. Therefore, further direct comparisons are required. They need to be adequately powered with survival free of major disability as the major endpoint. If you think that's bad enough, there has been another network meta-analysis done, published in JAMA Pediatrics now 4 years ago, which is even more complicated because it included inhaled drugs. And so you end up with all this sort of spaghetti going everywhere, and these are all the comparisons down here, trying to work out what's going on. So some of them involved dexamethasone, some of them involved hydrocortisone, but a lot of them were inhaled drugs. And they produced something called a sucra plot. And I don't have colour blindness, but I have a lot of trouble trying to work out from all these lines which is which in all these drug combinations down the right-hand side. And really, it's a very confusing clinical message to me. And from that network meta-analysis, they said moderately early initiated median cumulative dose of systemic dexamethasone had the highest relative risk reduction of mortality or BPD, with low confidence in its conclusion. And that was the best they could come up with from that network meta-analysis. So if you're confused, I'm confused, everyone's confused, I'm afraid network meta-analysis hasn't really helped us sort this out. We also tried an overview of systematic reviews, and I won't bore you with all the details, but the major conclusion was that late-initiated treatment with dexamethasone was considered effective, but endotracheal administration of budesonide and surfactant is promising, but not for clinical use yet, whereas early dex and hydrocortisone and late hydrocortisone are considered ineffective. And that's a review that's just come out just recently. And what about different corticosteroid regimes? Wes Odland and his group from the Netherlands have reported on this. And again, their conclusion is the evidence is very uncertain about the effects of different regimes on the outcomes of mortality, pulmonary morbidity, and long-term neurodevelopmental impairment. So whatever dose you're using, we're not sure is what's going on. They did say that perhaps moderate dose, 2 to 4 milligram per kilo versus high dose, 4 milligram per kilo, you might have a higher rate of cerebral palsy. That's based on 2 trials, a total of 74 participants, and those 2 trials were from the same stable of investigators. The first was the Cummings trial, which people probably know by its name from the 80s. Jim Cummings, the first author. And the second trial, about 20 years later, from the same senior author, Stephen Gross, with a similar sample size and similar conclusions. So they're the only ones who've been able to show this particular difference between moderate dose and high dose, largely because other people haven't directly compared the doses. But I don't think you can hang your hat on a 74 participants and say this is a confident conclusion that it's definitely causing more CP if you give a moderate dose rather than a high dose. My problem with all these different dose regimes is that almost all the studies are confounded by open label corticosteroids. And the doses given open label are far different to those in what are intended as starting doses, because all the studies describe their starting dose, but virtually none tell you what they actually gave, not the dose the infant received. DART is one of the few studies that actually reported the doses received. And just to highlight the difference for you, there were 35 children in each group in DART, so 35 of them were randomly allocated to dexamethasone, and they were to get 0.89 milligram per kilo in the first course. And what they actually got was 0.88, which is pretty good. In other words, people were weighing up and measuring up the drugs pretty correctly. And if they got a second course, they were again supposed to get 0.89 milligram per kilo. 10 infants did get a second course, and they actually received 0.87. However, some were treated with open label corticosteroids in both the dex group and the placebo group, and in terms of the amount they got open label, 3.9, more than 4 times more than what they would have got with just one course of dex within the DART study. And for the placebo group, the overall dose was lower, but more of them were actually treated. So there's a problem when we're talking about dosages. It's the starting dose, but you know clinically you might start a baby on a particular dose, and particularly if you start off with a DART dose, within a couple of days, some babies are not getting better and clearly getting worse, and you actually up the dose reasonably quickly. And many babies end up getting far more than the intended 0.89 milligram per kilo over 10 days. So what are the clinical implications here? So in terms of direct comparisons between inhaled and systemic, they're unconclusive. We're worried about inhaled corticosteroids, they don't really work. Systemic corticosteroids have benefits and risks, and we need to think of these risks in a little bit more detail. We've talked already about mortality and cerebral palsy being both outcomes are possible when you're starting treatment, and you can't have cerebral palsy if you don't live long enough. So a number of years ago, now nearly 20 years ago, a group of us got together and asked ourselves, is long-term outcome related to the baseline risk of BPD? And this was published in Pediatrics 19 years ago. And what we effectively did was look at this outcome of total cerebral palsy risk difference and flip it on its side, you've got effect on death or cerebral palsy risk difference. And above the line is bad because it's an increase in that bad outcome. And below the line is good because it's a decrease in that bad outcome. And plotted the individual study results versus the rate of BPD in the control group. And the size of the circle is proportional to the contribution of that particular study to the overall relationship. And when you look at these particular dots being plotted, you can see without me drawing a line that there's a negative slope. And if you actually plot the line at its confidence intervals, that's the slope that you see from these 14 studies. And it has a particular equation associated with it. When you solve, or when it crosses the zero value, it's roughly 50%. What it's saying is above a risk of 50%, you start to see net benefit. Below a risk of 50%, you're starting to see net harm. And note the confidence intervals here are away from the null value. Now, between 2005 and 2013, more studies appeared, 6 in total. So from the original 14, we now had 20, and one of them was the DART study. So we did it again. These were the new studies. This one out here on the right-hand side, did the equation again, and here it was a little bit tighter and a little bit left shifted. So this confirmed what we said earlier. Well, the risk is related to the rate of BPD in the control group. Now, of course, 10 years since we did that, and there are 6 more studies with long-term data on the risk of BPD and cerebral palsy. So we're now up to 26. And 4 of these new studies are randomized controlled trials of hydrocortisone. So now there are enough studies to actually ask the question, is there a difference in this relationship between dexamethasone, 18 trials, versus hydrocortisone, 8 trials? Now, if we look at the overall relationship, now we can see the negative slope is looking less impressive. Same thing as what I showed you earlier. But we need to look at the hydrocortisone studies here. And with the eye of faith, you might think there's a slope going upwards. And if you actually plot it, yes, there is. I note the confidence interval here. Whoops, sorry, I didn't mean to put that up. I'll get rid of that. It's just starting to approach the line of zero, suggesting that as you get to a low risk, maybe hydrocortisone might be doing you good. And the dexamethasone studies show you the old relationship where you're crossing the line again at 50%, and the benefit increases in terms of once you get above 50%, and the evidence becomes more convincing once you're getting above 70% risk of BPD in the control group. Do postnatal corticosteroids do more good than harm, or harm than good? If the risk of BPD is high, dexamethasone may do more good long-term than harm. And so in clinical practice, you should be reserving dexamethasone for those at high risk for BPD. However, if the risk of BPD is low, you must avoid dexamethasone. It's harmful if the risk is low, because the baby can't benefit from the reduction in BPD that would be associated with bad outcomes, and the risk of the dexamethasone itself outweighs those risks. What about hydrocortisone? Potentially may do more long-term good than harm, but it really needs more research. Who might benefit? Low-dose hydrocortisone in the first week needs more work. You definitely need to be at high risk of BPD, and that really boils down to being beyond the first week of life. Low-dose is appropriate to start. And the good thing about the DART studies, even though it was an aborted trial, we still got babies extubated. We reduced their FiO2, we reduced their ventilator requirements. So it was good. But hydrocortisone, we don't know about. What are the research implications of all of this? The conclusive trials remain a challenge, basically because clinicians can always use the drug open label. It's complete contrast with the surfactant trials. We couldn't get our hands on surfactant clinically while the trials were being done. So there was no contamination with open label surfactant. And the surfactant question was answered pretty quickly. Yes, it's good stuff. We would have had the same answer with corticosteroids if there had been no contamination, no open label use of corticosteroids. But people become steroid dependent. The doctors become steroid dependent. They can't let a baby die without giving a corticosteroid. So That remains a challenge today. Other corticosteroids and modes of delivery look promising, particularly in intratracheal installation, but we've got this concern between the difference between our local study and the rest of the world, and we need more data on the long-term outcomes and results of other trials before we jump down that route clinically. For me, a head-to-head late trial of dexamethasone versus hydrocortisone could be justifiable, and there's definitely a need for another randomized trial of early hydrocortisone versus placebo. In the meantime, please continue with all your attempts to reduce BPD through whatever mechanisms you might be doing. We're not having much success. It's remaining a stubborn condition. And again, I'm sorry, I have to remember what I put down the bottom. Avoiding endotracheal intubation, reducing oxygen exposure. How you do it, I don't know. So what's happening today? I know non-intubated babies are receiving corticosteroids. In all the randomized trials, virtually every baby is intubated. There are some exceptions, but there are no reports of non-intubated babies solely receiving corticosteroids in randomized controlled trials. So all of you who are giving corticosteroids to babies who aren't intubated, you're doing it on the basis of no evidence. I know babies on high flow, low flow, and minimal oxygen are receiving corticosteroids. I hear about this because I hear the gossip. And many of these babies are going to be well beyond 36 weeks post-menstrual age, well beyond the age when you make the diagnosis of BPD. So what do you do? There's no evidence to guide you, but the risk from lung disease must be low in these non-intubated dependent babies. And to me, if they're at low risk, you must avoid dexamethasone. So what are the take-home messages finally? If you're using betamethasone, prednisolone, please stop using it on the basis of no evidence. The direct comparison between inhaled or injected versus systemic is inconclusive. Inhaled, no. Intratracheal, yes, I think this is the most promising, but we need more work. Systemic, yes, late. It must be at high risk for BPD. And we need to complete the work on the intratracheal administration. So I think that's about it. I need to acknowledge my co-authors on the Cochrane systematic reviews and also the overviews of postnatal corticosteroids. There's a message here. You work with Doyle, you end up dead. Just be wary of that. And I need to acknowledge the co-authors on the network meta-analysis and the overview of corticosteroids. And thank you for your attention. And I'll stop sharing the screen. I hope that stopped sharing, has it?
Yeah, it's still sharing. Thank you so much, Lex.
Still sharing. So,
yeah.
I need to stop sharing. Where do I stop sharing?
Down the bottom, if you just...
Yeah, no, I can see that. It says share, and I don't want to stop share.
Okay,
that's got me out. Okay.
Lots of questions. I was going to give the first question to your buddy Jeannie about high flow, but you answered that, right?
Okay. I can't see where are we?
Yeah. That's Jeannie. She was going to ask the question about the use of Dex while the baby's on high flow, establish BPD on high flow. And someone's asleep.
Sorry. She's not asking the question. I can't see it. Oh, there she is.
There she is.
No, you already answered it. So the concern about the therapeutic drift for people to wanting to give postnatal corticosteroids to babies on high flow or low flow oxygen in an attempt to get them off. But I think your message was loud and clear that there is no evidence to guide that practice. And if it's currently happening, people have to think very carefully about what evidence is driving that practice. So thanks, Lex, for covering that. I see a lot more hands, so I'll shut up and turn off my video.
Thank you, Jeannie, and thank you, Lex. Look,
there's a couple online, Julie. There's one about prednisolone from a doctor in Bangladesh. Now, as I've said, there's no evidence for prednisolone. So if you're using prednisolone, you're using it on the basis of no evidence, Dr. Hararam. So I would suggest you stop using it and consider using dexamethasone instead. Now, if you can't get dexamethasone, that's a different story. I think if that's prednisolone's the only corticosteroid you can get, then you may have to, I think you might be justified using it. But as I said, it's on the basis of no evidence. There's a second question about the rate of intestinal perforation in plus. And I'm sorry, I can't give you that information. Brett would be able to. It was not different between the two groups, I know that, but I don't think it was particularly high. And there's another question about what tool would you suggest to determine the risk of BPD in an individual infant. There are a couple of tools out there that are being derived on different populations. The American tool, I think, in our local population was not very accurate. One of our fellows reported this a few years ago, Liz Baker. So we couldn't translate that particular tool into local practice. I suggest you develop your own tool in your own population to work out who's going to get BPD. No, clinically, that it's a baby who's stuck on the ventilator, whose oxygen and pressure requirements are going up in the wrong direction beyond the first week of life. They're at the highest risk, but exactly what risk you can't say. And I don't have any current tool that I know is available for Australia that would work. So please develop your own tools will be my suggestion.
I think that's really urgently needed. So Lex, we might go to Manto and then to Sam and then to Somil's question. Is that okay?
Yeah, sure.
So Manto from Darwin. Manto, you have unmasked yourself. All right. So Manto's asking if it's unreasonable to use steroids to prevent re-intubation in high-risk prems. Very good question.
Yeah, good question. And as I said, the data relate to babies who are intubated when they get into the trial. So you're talking about a baby who's not intubated, therefore there's little evidence to justify using corticosteroids. Now, I know in clinical practice that this is almost certainly happening, where the baby's oxygen requirements are going up.
I'll just mute.
where the oxygen requirements are going up, and probably they're on non-invasive support, such as the CPAP pressures rising or the flow rates are rising if you're using high flow. So I can understand why people might want to start corticosteroids. But all I can say to you is you're doing it on the basis of no evidence to support it. But I can understand why clinicians might opt for that particular choice. And I can't say that I would or I wouldn't do it today because I don't work in the nursery anymore. So I'm sorry, I'm not very helpful to answer that question directly.
Manto? You can unmute yourself.
Oh, yeah, look, I think it's probably nothing that's going to help with evidence as such, because it's, just a handful of cases where in practice, you've had a baby who's maybe on NIPIV and high pressures and very high oxygen and we've given them steroids and they've gotten better and they need to be re-intubated and managed to transition them to CPAP, for example. So that was the context for the question.
I appreciate the context and I understand your dilemma. And I suspect if I was in the nursery and I was faced with that dilemma, I probably would start steroids rather than put the tube down if it was on a really high concentration of oxygen and clearly heading towards BPD, which is what you are describing.
Okay, Sam is waiting patiently.
Right, yeah. Lex, wonderful talk you always, give. And I have been hearing you for more than 30 years. The first talk, 88 or 89 in Melbourne. One message, you choose antenatal steroids. That's what I remember. That was the one message at the end of your talk you said. I think you talked about outcome in that meeting organized by Professor Victor Yu. Now today you have given lots of conclusions. My question is, none of these trials were powered to look at the development. The DOT one, your primary aim was, is it safe, developmentally without BPD and so forth. But unfortunately, we couldn't proceed with the trial. Many of the trials were, incomplete, like Christy Waterberg. Perforation was high and the data monitoring committee stopped it. So only the rest of the babies were analyzed. Now, my question is, putting together, 20, 30 years data and doing a systematic review, is it better? Or a single or a couple of large trials like PLUS and looking at the neurodevelopmental outcome, which will give the right message.
If you had a choice, Sam, you would go for the big trial done properly with hard endpoints done by experts with no contamination, and that will give you the clear answer reasonably quickly. That would be my guess. The problem is keeping the clinicians' hands away from the open label corticosteroids, because they will always use them if the baby's going in the wrong direction, and that really makes it very difficult. And there will always be trials that stop early. Why did that stop early? Because the pendulum swung so quickly and so rapidly, such that we started off with a group of people who were in equipoise, and then everyone said, you must stop using corticosteroids, and everyone stopped using corticosteroids, and those who were in equipoise went into that camp, and you couldn't get the steroid-dependent people in the midpoint to join the trial. And so we just went south with recruitment. We recruited 70 babies over about 3 years. We needed 800 plus. So we had to stop the trial. So unfortunately, you're then left with a mismatch of trials of different sample size and different reasons why they stopped and started. And you then got to try and make sense of that evidence. And the only way to do that is to do a thorough systematic review and try to pick the bones out of it. It's better than no evidence at all. So that's the alternative, is just do willy-nilly with no evidence whatsoever. So I think, to answer your question, a big randomized trial, more applicable around the world, multi-center, that would be fantastic. It won't happen. I won't live to see it, but if it does happen, strength to whoever is able to do that, pull that off. Second best is a systematic review, and worst is no evidence whatsoever.
Okay, my other question is, nowadays we use antenatally from 22 weeks onwards, betamethasone, 50% of the obstetricians, or dexamethasone. The baby may be exposed to 2 courses, and as you know, below 25 weeks, this has not, fully studied, maybe except one large randomized study. And then postnatally, 1 week later, these babies are invariably ventilator dependent, majority of them. And then we give dexamethasone to prevent BPD. Anybody has analyzed, put together antenatal dexamethasone, 1 or 2 courses, postnatal early, not early, moderately late dexamethasone. Is it beneficial or harmful? The challenge now is 25 weeks and below.
This sounds like a wonderful question for you to ask yourself in your own data, what's going on in Singapore with respect to the interrelationship between antenatal and postnatal corticosteroids. I don't have any information for you on it. I don't know of anyone who's looked at the particular question. There certainly wouldn't be a double randomized trial combining both antenatal and postnatal corticosteroids. I know that won't exist. So you'd be dealing with observational data in one or other category, and so that would have all the flaws potentially of observational data. But yeah, it's an interesting question. In this part of the world, we're still using betamethasone. Dexamethasone does work as well antenatally, but we don't use betamethasone postnatally. And as I said, there's no evidence for betamethasone postnatally. It started off being Dex, and it's continued to be Dex or hydrocortisone, and the other drugs are just being used by clinician personal choice on the basis of no evidence. So it would be an interesting question to look at, but I don't have the information for you, Sam.
Thanks a lot.
We might have to move on. Just 2 last questions, apart from all the compliments for your talk, Lex. All right. So one from Dr. Desai is about, the Japanese practice of keeping the babies intubated until 28, 29 weeks, but still reporting lower BPD rates and higher survival. What do you think about that? And then the last one, I guess, what I would give to Simone from Darwin. I love Darwin. They have a lot of wild things happening there. So maybe you can take the first one on.
Please, one at a time, really. My memory doesn't stretch to more than one question at a time
So
these days.
The Japanese one first.
Yeah, I wasn't aware that that was Japanese practice to keep babies intubated until they were 28, 29 weeks. My own personal view would always be to get the endotracheal tube out. If that means higher CPAP or more high flow or something like that, so be it. I must say I don't have clinical expertise in high flow because it came into clinical practice after I resigned or retired from clinical practice. So I do have experience with high CPAP pressures, high nasal CPAP pressures. And I think having the endotracheal tube out was always preferable to me, but I don't have any evidence to suggest that's better or not. Have the Japanese actually done a randomized trial to show that that is good? Because if they haven't, then perhaps they might consider doing that. And the second question?
Second question, well, Simone has unmasked herself. I'll let her talk because it's so long.
Sorry, thanks, Lex. Always great to hear your perspective and your and the many hours of thinking that you've put into these things. I guess my question relates to cumulative dose exposure, given the open label use of dexamethasone in so many contexts, and I'm wondering whether the network meta-analyses have done when they did those, looking at moderate and low versus high dose dexamethasone and their outcomes, was that all based on reporting as per protocol dose exposure, or was that cumulative? Like, is there any access to the cumulative dose exposure that children received in terms of long-term outcomes that might then account for the open label use?
Okay, Simone, the only trial that I know of for sure that's reported the actual dose received is the DART study. I think there might be one or two others of the 50-odd randomized controlled trials that may have reported that. I just, at my fingertips, I can't say definitely or not, but the majority have not reported the dose received. So all they've talked about is this is the starting dose. And so all the work that's been done on dose has been on the basis of what the starting dose was going to be. But as I said earlier, in practice, you know that you start off with a particular dose, particularly if it's low, i.e. DART, and then you have to increase it in many babies because they just don't respond as you would like to see. The problem with then working out what the cumulative dose received is, that's a post-randomization event, and it's always going to be biased by the fact that the sickest babies are going to get more steroid, and therefore they probably would have ended up with the worst outcome anyway. So once you get beyond the randomization or the starting of the trial, cumulative dose is a little bit problematic to try and sort it out. But almost certainly those who get more are probably going to do worse. But it's not just the dose that they've received, it's the fact that they were sicker anyway, or they were destined to be sicker anyway, and that's why they have a worse outcome. So dose is a tricky thing.
Okay. So thank you. Unfortunately, you're way out of time. You had more than 160 people online, Lex, plus multiple tutorial rooms. So this is an incredibly hot topic.
Good.
Thank you so much. And I'm sure that people will be asking you questions online or by email. Is that okay?
Yeah, I'd be very happy to receive emails. I think you probably...
Oh, look, you
got
have a
email.
little clap as well from Mento. Look at that. Thank you, Mento. All right, so we'll go through the recording, make sure that no one's doing anything weird on the recording, and if it's okay, we'll post it on our group chats.
Okay, thanks, Julie. Thanks very much for having me,
So
everybody.
much. Thank you so much for your time, and thanks, everyone. See you for the next one.
Bye.
Bye. Bye. Have a great day.
Recording